Chapter 13 is going to be on the nutritional requirements affecting oral health in women. And this starts on page 235 in your book. All right, so up until this point, every time your book has referenced the differences in nutritional recommendations between men and women, they are talking about women who are of childbearing age, but who are not currently pregnant, who are not currently breastfeeding, and who have not yet reached menopause. So they are only talking about the very specific time after adolescence, but before menopause, and not pregnant, not lactating. So this chapter is all about those specific life stages of what happens before and during pregnancy, what happens with breastfeeding, and menopause as well. Those are the three things we're going to talk about here. So the first up is the pregnancy, healthy pregnancy. In order to have a successful pregnancy, the main factors we need to focus on are the nutritional status before conception, and how much weight is appropriate to gain during pregnancy, and those essential nutrients to take in during pregnancy as well. So, how much or the person weighs before they got pregnant, and what their overall nutrition was before pregnancy, how much weight they gained during, and what they're eating during. But what exactly is a successful pregnancy, right? What defines a successful pregnancy? Well, it's going to be, first, the goal for the infant in order to be considered successful is that it is full term. I say it, that's terrible. He or she is full term. And that means they're going to weigh full term means that they are between 39 and 41 weeks gestation. Premature is any time less than 32 weeks. And in 2014, they did a study, approximately 34% of all infant deaths were born at less than 32 weeks gestation. Gestation obviously being the amount of weeks that the mother is pregnant. The other thing is to be mature, which in this way means that they are weighing more than 6 pounds. Anything less than 5.5 pounds is considered low birth weight. And so those are the two things you need to learn from this section. Is going to be low birth weight, anything that is 5.5 pounds or less, and premature, which means that they have a gestational age of less than 32 weeks. You can see more information on this in figure 13.1, which is at the bottom of 236, and table 13.1, which is at the bottom of 237. So we're going to talk about the factors that will affect fetal development. And these are going to be the preconceptual nutrition status. So what the woman's nutritional status was before she conceived. It is the most important time for prenatal care, is before ever getting pregnant. So your book does talk about the weight of the individual. It needs to be addressed in order to prevent health complications. And they go into preeclampsia, which is a potentially serious complication of pregnancy involving high blood pressure that often leads to premature delivery. So someone who has uncontrolled blood pressure issues that issue can send them into having a premature birth. Approximately 50% of all pregnancies are unplanned. The inadequate intake of folic acid prior to pregnancy and in the first weeks of gestation can result in neural tube defects. We've already talked about that, right? Folic acid is associated with neural tube defects. However, all of those things that are necessary, the amount of folic acid the woman needs to have in her system, is typically crucial before she ever finds out she's pregnant. So if half of all pregnancies are unplanned, it means they didn't mean to get pregnant, and they don't know they're pregnant until after a lot of those critical points are already passed, right? In the first, some women don't find out for a month or maybe even more than a month that they're pregnant. So a lot of those developmental stages are already done. And so if the woman is deficient in certain vitamins or minerals, then it can certainly affect fetal development. Low levels of iron and folic acid are linked to premature births and stunted growth. And inadequate iron and calcium intake can deplete the mother's stores and lead to infant store being suboptimal at birth. So we're going to talk about each one of these nutrients and where the infant gets it and how it affects the mother during pregnancy. So your book starts talking about Pika, which is an abnormal consumption of specific foods or non-food substances like paint chips, dirt, clay, all kinds of non-foods, right? Pika is not actually something that is pregnancy associated, right? It's just something that we hear about when women become pregnant. So there are, if you guys ever watch TLC, there's like those My Strange Addiction shows where people eat all kinds of things. Like I saw one where a lady ate cat hair. So there's Pika, which is unusual consumption of food that's not food, and it is somehow it's linked to pregnancy, like the overall conception of it, because a lot of women think that it's a normal aspect of being pregnant, and they think that it's something like your body's missing something like iron or whatever it is, and so they think that's what leads Pika to happen, but that's not the case. It's actually opposite. So Pika, which is it's actually nobody knows why they do this. It's an enigma, and it can lead to nutrient deficiencies, especially iron. So it's not reverse. The deficiency doesn't cause Pika. Pika causes deficiencies. And we see it more so in lower socioeconomic groups, so poverty. Anyone who has less than a high school education, obviously, higher educated individuals are less prone to do things just because, for no reason. Poor nutritional health, so someone who, they're not getting all of their nutritional needs, so then they think that eating Tide Pods is normal. And then behavioral, environmental factors like substance abuse, those are some of the risk factors for that kind of issue. So Pika can actually lead to lead poisoning or any kind of, most of the time we see it like the bola of whatever is created. It gets caught and they have some type of obstruction. Sometimes they have to have surgery for that kind of thing. So it just depends on whatever it is that they're eating. But as far as like oral care goes, whatever they're eating can actually be pretty damaging to the teeth. So it just depends on, what they're eating. If they're eating cat hair, then, that's probably not going to cause a lot of damage. But if they're eating like, dirt, then it's probably going to cause a lot of wear to their teeth. So you might want to ask some questions if someone comes in with a lot of wear. And then they talk about cravings. Cravings are not really something that we have to associate with Pika. They're not the same thing. And then a lot of the time it's more cultural or regional, and cravings can either cause the individual to consume too many calories, or it can cause the individual to consume poor nutrition. So we want to be mindful of cravings. Another aspect is going to be healthcare access. So a woman who has healthcare is going to be able to receive prenatal care and prenatal education as far as nutritional requirements, whereas someone who doesn't is not going to be able to do so. They may not know to take a prenatal vitamin. Or they may not know, how to go about taking those things. And then it says it could be related to chronic health problems in later life. So, if there's some type of nutritional deficiency or, a lack of health care in a woman when she is pregnant, then it can affect the fetus and then the fetus, in their life. Age is another big factor in fetal development. So whenever there is a teen pregnancy, an adolescent who is less than 18 years old gets pregnant, there is an increased risk for low birth weight. The main problem here is that adolescents have their own nutritional requirements. They have their own needs, and it's a pretty crucial time in a woman's, life stages that she is able to use all of the nutrients she's consuming for her own body and not have to give some of that nutrient to a baby. And so the majority of adolescents actually have an inadequate intake of calcium, iron, vitamins A and D, niacin. I don't know why they don't just say B3, but they don't. And then also kilocalories. And so when we're going to talk about it, but when a woman is deficient in calcium, the baby will actually take the calcium from the mother. And so in this, whenever they see teenage mothers, 1 in 3 of them show signs of significant bone loss. And then the other one is pregnancy after the age of 35. And the big issue with this is like chronic diseases. So maternal risks include diabetes, hypertension, and cardiovascular disease. And when a woman becomes pregnant after the age 35, there is an increased risk of myocardial infarctions, which is heart attacks. So then the next factor is going to be weight gain. So how much weight should a woman gain during pregnancy? And the answer is that it fluctuates from trimester to trimester. In the very first trimester, she shouldn't gain any weight. There should be no difference. In the second trimester and the third, it should be anywhere from 0.8 to 1 pounds per week during only the second and the third trimesters. And it should be a total of about 25 to 35 pounds, depending on the individual. Women who start out kind of underweight, they should gain a little bit more, probably closer to 35 pounds, whereas a woman who is sort of at the top of her BMI of healthy, then she should shoot to gain about 25 pounds. Inadequate weight gain is going to be associated with low birth weight. Obviously, if she's not eating enough, the baby isn't eating enough. And then excessive weight gain is going to be associated with high blood pressure, miscarriage or stillbirth, and difficult deliveries. So we talked about preeclampsia, where that high blood pressure can cause the woman to go into labor early, which could lead to premature deliveries, or it can lead to miscarriage and stillbirth earlier in the pregnancy, and then also difficult deliveries. So if she's gaining a lot of weight during the pregnancy, then the baby's going to gain a lot of weight, and it's going to lead to like 12-pound babies, and so that's going to be pretty difficult to deliver. And then children are more likely to be overweight at age 3 if the mother gained excess weight. I think this has a lot more to do with the lifestyle that the mother has. If she gained excess weight during her pregnancy, then she might eat certain types of foods that are maybe not as healthy, and so then the children end up being overweight as well. Although there are links to flavor and things like that during the pregnancy that children develop an affinity for later. It's also the part of the book where they begin to refer to pregnant women as gravida. So anytime your book says a gravida, it means a pregnant woman. And anytime your book refers to a prima gravida, it means she is in her first pregnancy. The next factor affecting fetal development is going to be the oral health of the mother. So typically a little bit more than half of pregnant women will receive dental care during their pregnancy. And some of the issues with why women don't receive dental care is that there are attitudes and behaviors about dental care during pregnancy that are influenced by fear of harm to the fetus. So, when we hear that, when you're pregnant, you shouldn't get x-rays because it could harm the fetus, or, if you go get your teeth cleaned or you go have work done, then, it can lead to, having like an unexpected delivery, like you go into premature labor, those kinds of things. Those aren't true. So routine dental care during the second trimester, which is anywhere between 13 weeks to 21 weeks, is not associated with any increased risk of serious medical events. It's not associated with preterm delivery, spontaneous abortions, or fetal death or anomalies. So it's actually really important to go get your teeth cleaned during your pregnancy because it can decrease your gingivitis during the pregnancy. So it's pretty important. Keeping with oral health, it's time to talk about hormonal changes. So during pregnancy, obviously estrogen and progesterone are very high in the mother's system, and they contribute to an increased susceptibility to gingivitis and periodontitis. And so we see more bleeding and more swelling, right? So studies indicate periodontal disease during pregnancy is a significant risk factor for preeclampsia and or delivering premature or a low birth weight infant. A lot of mothers don't understand this or know about this, but it's really important to get your teeth cleaned in order to remove a lot of that harmful bacteria and to try to prevent low birth weight. I had learned that always, that periodontal disease was associated with low birth weight. And then any woman who's been pregnant understands that morning sickness, nausea, vomiting, gastroesophageal reflux are pretty common, and this is going to have a pretty strong, effect on your oral health. So it says nausea is common during pregnancy. Recurring vomiting increases oral exposure to gastric acid secretions. Another factor affecting fetal development is going to be the intake of drugs and medications. So caffeine, it says more than 7 cups a day of coffee, is associated with low birth weight and a risk of miscarriage. Excuse me. American Dietetic Association maintains that pregnant women should not consume more than 200 milligrams of caffeine, which is less than 2 cups of coffee per day. Most of the time they tell women to just not drink any coffee whatsoever, and a small amount of coffee isn't going to harm the baby, but no more than 200 milligrams. So 1 cup is good. And then alcohol is a folic acid antagonist, and so it may lead to fetal alcohol syndrome. It is the very last page of this chapter. Let me find it. The image of fetal alcohol syndrome symptoms is going to be on page 253 at the top. And so if you are consuming alcohol regularly during the pregnancy, then it's going to, you guys will learn what an antagonist is in pharmacology, but it's going to basically block our body's ability to absorb folic acid. And so that could lead to not only neurotube defects, but it could also lead to fetal alcohol syndrome. And then they do recommend consulting a healthcare provider anytime for any prescription or over-the-counter medications, or even herbal remedies as well for during pregnancy. As far as artificial sweeteners go, non-nutritive sweeteners that are generally recognized as safe, and that's the acronym, for generally recognized as safe is GRAS, can be used. So saccharin, all of those, they're considered safe in acceptable amounts. The exception, of course, is going to be for pregnant women who have fetal phenylketonuria, which means that they can't consume aspartame, and so obviously they can't have aspartame. And then food safety is going to be women who are at a high risk for foodborne illnesses. So foodborne illnesses such as listeriosis can cause miscarriage, premature birth, stillbirth, or acute illness of the newborn. So it's important, that you wash vegetables and fruits and any kind of produce, and then that all meat is cooked to the acceptable, it's 165 degrees Fahrenheit, which is the like temperature you have to cook food to, and then to avoid all unpasteurized juices and milk products, raw sprouts, raw or undercooked meat like sushi, any type of raw or undercooked poultry, to avoid raw eggs, raw fish, and of course raw shellfish. And then your book goes into toxoplasmosis, which is not the same as listeria or listeriosis. So listeriosis is caused by a bacteria that is a foodborne illness, and then toxoplasmosis is actually caused by a parasite. This is why you hear that women shouldn't clean cat boxes, because that's a way of transmission. And so pregnant women have to be careful as far as what they're exposing themselves to when it comes to bacteria and parasites. Women are encouraged to consume at least 8 ounces, which is 2 to 3 servings of cooked seafood weekly. However, should be a mercury-free source. So while tuna is considered a source of fish for non-pregnant individuals, they do tell pregnant women to avoid tuna because it's high in mercury. All right, and since you guys already took histology and embryology, you already know that tooth development will typically begin by the 6th week of gestation. Anytime there is a severe nutrient deficiency, it can result in malformations of the cleft palate, cleft lip, and a shortened mandible. Nutrient availability affects whether teeth achieve their optimal genetic potential. So if the mother is deficient in all of those minerals that are necessary for tooth development, like calcium and phosphorus and zinc and iron and all that good stuff, then the teeth of the baby won't develop as optimally as they should. Typically by the 4th month of pregnancy, the calcification of those deciduous teeth begins, and the mandible is calcified as well. So severe and irreversible damage results if nutritional insult, which I think is a hilarious way to say a deficiency, or excessive amounts of specific nutrients, which is either not enough or way too much of, is a nutritional insult. Or infection occurs during critical stages in dentin or enamel formation. And here they talk about infection because if the mother gets like a very high fever and it disrupts her calcium and phosphorus balance, then it could affect the fetal's tooth development. Dentin and enamel will depend on vitamin C for formation of collagen matrix and calcium, magnesium, phosphorus, and vitamin D for mineralization, right? So if the mother isn't optimal in all of these nutrients, then the baby won't get them either. As far as fluoride supplements go, now the book is pretty clear. There's no real need to provide supplements to the mother because the baby really doesn't need that much. And there's no research that shows that even when they do supplement, that it has a very, good effect. So they do encourage fluoridated water, as they always have, and then fluoridated, oral hygiene products like toothpaste and mouth rinses and things like that for the mother, and then whatever residual that she absorbs systemically through fluoridated water is what the baby will use and is all that the baby needs. So pregnant women do not need to begin taking fluoride supplements. You'll find a lot that women decline having fluoride when they're pregnant because they aren't sure if it's safe, and it is. So there's no contraindication of pregnancy for fluoride treatment in the office because it is a topical treatment. It's not like a fluoride supplement. Before we get into this nutritional requirements for pregnancy and breaking down each of these requirements, I do want to remind you, this is going to be on page 241, table 13.3. These are the nutrient deficiencies and tooth development, like how those nutritional deficiencies specifically will play a role in the effect on the tissue. And so table 13.3 is something you're going to want to bookmark, and then, probably years from now, you'll be like, talking to a pregnant woman and you'll be saying, how important her nutrition is according to the baby developing properly. And she's going to be like, really? How? And this is the page you're going to want for that conversation. So bookmark this page and come back to it because this happened to me and I didn't remember and I kicked myself for months. So bookmark this page and come back to it later. Anyway, moving on to the nutritional requirements for pregnancy. So the dietary reference intakes for pregnancy indicate advisable nutrient intake for optimal health of the mother and fetus. And these are the recommendations they make for each of these types of nutrients. So first is energy or kilocalories, right? How many total calories you eat. And you do not need to increase it for the first trimester. In the second trimester, they recommend an additional 340 calories. And for the third trimester, they recommend an additional 452 calories. So when they say that the mother is eating for 2, that doesn't mean she gets to double her calories. That's going to cause excess weight gain, right? So we have to try to remember that the baby is tiny and they don't need that many calories. They only need a little. They're little. So during the first trimester, no additional calories, and it just slowly builds from there. And then obviously those calories extra that you're consuming, you want to be wise food choices. So you're not going to eat, Oreos for breakfast just because you're pregnant, right? We want to choose nutrient-dense foods. Anytime, by the way, you'll see this on your boards, anytime they say nutrient-dense, they mean low calorie, okay? So anything that's super nutrient-dense is going to be low in calories. Anything that is very high in calories is going to be low in nutrient density. And then for fat, the serum cholesterol and triglycerides will become significantly elevated during the second trimester. This is when the baby is really starting to kick off with developing and needing a lot more fats. All right, so as far as protein goes, the mother is going to want to consume an additional 21 grams of protein per day. So while they had their normal amount, this is adding the 21 means that they should be having a total of a minimum of 67 grams of protein per day is going to be that recommended amount. This is going to be accomplished by an additional 3 ounces of a meat or a meat substitute, or by adding 2 ounces of meat and 8 ounces of milk to the diet in order to get that amount of protein. As far as calcium and vitamin D goes, I think this is one of the coolest things about the human body is that you don't actually need to consume that much more calcium and vitamin D. The requirement for consumption isn't changed. It's actually just that the mother begins to absorb more. So I don't know about y'all, but I think that's really cool. The only caveat to this one is that if it's a teen mom and she's an adolescent, she is already probably deficient in calcium and vitamin D. And so while the teen mother normally is supposed to get 1,000 milligrams a day of calcium, now she's going to need 1,300 milligrams a day if she is 19 or younger and pregnant. And then for B vitamins, all of the B vitamins are important, but especially folate. So folate or folic acid is going to be associated with neurotube defects. However, it is also associated with orofacial clefts, right, which are like the cleft palate and cleft lip. Neurotube defects we've already talked about, but then also things like spina bifida and anencephaly. So all of those conditions in the infant can occur if the mother doesn't have the proper amount of folate in her diet. And I mean, this is usually like, you have it in your diet all the time. So because of this, the United States in 1996 actually implemented supplementation on their fortifying foods with folic acid. Because of this, neurotube defects here in the US have fallen 35%, so a lot less. And then they also talk about Hispanic women and how even though they had added the folic acid to a lot of foods, they were not typically foods that Hispanic women were consuming. And so since 2016, the FDA approved adding folic acid fortification to like corn maize or the ground corn flour. And since then, Hispanic women haven't had as many issues with infant issue, like folate deficiencies. As far as iron goes, during pregnancy, the recommended dietary allowance is going to be 27 milligrams a day. There is a higher intake of iron during gestation, and this is because the mother is now having to produce red blood cells and the placenta to create all of that from nothing. And to compensate for cord and blood loss at delivery. So, as the placenta tears, there's obviously some bleeding. And then supplementation is recommended when it comes to iron because not all iron is easily absorbed. And so, you need to supplement it with vitamin C. So vitamin C and iron absorb really well together. If you try to have iron, you try to take in iron at the same time as calcium, you're going to have a hard time absorbing it because it will block it. So absorption increases from 10% to 20%, and then it says to approximately 25%. I'm not sure what that is, but your absorption of iron is going to increase during pregnancy. And then as far as zinc goes, the recommended dietary allowance is going to be 12 milligrams per day. The book actually calls the fetus a parasite at this point. And it says that in the formation of red blood cells will occur at the expense of maternal iron stores. So they will completely deplete the mother of iron before the baby is deficient. And then in premature infants, having a shortened gestation and have insufficient time to acquire adequate iron and may be born with an iron deficiency anemia. Fortunately, premature infants absorb iron really well, so that's not an issue. Your book also talks about how, after pregnancy, if you get pregnant again very quickly, then, you haven't had a chance to replenish, the mother hasn't had a chance to replenish her stores. And so going into a second pregnancy right away is going to have a lot more nutritional requirements. As far as iodine goes, so the recommended amount is going to be 220 micrograms per day during pregnancy. They found that the amount of iodine consumption in the United States has actually been falling because a lot of people are switching from regular table salt, which is iodized, to sea salt, which doesn't have iron in it or iodine in it. So they're seeing that fall. And so even though we're eating just as much sodium as we have ever eaten, we're not getting as much iodine as we need to. And as we know, iodine is very important for thyroid function. And then vitamin and mineral supplements. So the Institute of Medicine subcommittee concluded iron is the only nutrient warranting global supplementation during pregnancy. So for the most part, we get everything else except for iron, and we really need that during pregnancy. Supplement composition should be based on an identified nutritional need. So you shouldn't just eat all the supplements just because you know how important they are now, right? Just because you take nutrition doesn't mean you should go out and start hoarding vitamins. Don't do that. Eating a healthy, well-balanced diet, fruits and vegetables, kind of having some variety, you're going to get what you need. And then high risk is anytime they need supplements. So like adolescent pregnancy, anytime there is more than one baby, so twins or triplets or more. And then anytime there is use of like cigarettes, alcohol, or other drugs, that's when supplementation is really important. So prenatal nutritional care is going to improve the outcome by saving lives, right? It's going to help prevent miscarriages and stillbirths and things like that. It's going to avert low birth weight, right? It's going to make babies healthier, and it's going to decrease costs of care, because when you look at it from a government standpoint, anytime they can, reduce cost, is public health systems worth the money you have to put in? Will we end up saving that much money in the long run? That's what they care about. So if you go to the myplate.gov website, it does have a lot of helpful links, and in it will include food plans for pregnant women. That's going to help to give some guidance for how to modify the diet during pregnancy. Some pregnant women may have little or no nutritional knowledge. I mean, I know I certainly knew nothing about nutrition whenever I was pregnant. And then low-income women may benefit from a referral to the Supplemental Nutritional Program for Women, Infants, and Children. So there's a government program called WIC, and in it they do discuss nutritional recommendations with pregnant women, and what to eat during pregnancy, and what to eat during like the first few years of the baby's life. And then they can identify fad dieting, Pika, and other risk factors in the so like a nutritionist basically who works for the Supplemental Nutrition Program can help to identify those. It's also a good time to talk to the mother about breastfeeding and how important breastfeeding can be for the baby, which we'll talk about when we get to lactation. But then also during the pregnancy is a good time to talk to the mother about oral care for infants. So anytime you have a pregnant woman in your chair, especially if it's her first baby, right? So if she's a prima gravida, then you want to talk to her about how to take care of an infant's oral health. So, not giving them a bottle at night, or, putting them to bed with a bottle and not giving them juice in a bottle, and like using a washcloth to wash their gums, and when to begin flossing and when to bring the baby in for their first dental visit. All of those things are things you want to be talking to the mother about while she's pregnant, because the last thing you want is for her to disappear and then come in with a 2-year-old that has rampant decay because she didn't know. All right, so for the purpose of this chapter, we're actually not going to get into like how important breastfeeding is. We're just talking about the mother's role in all of this. And so the recommendation is that the mother will breastfeed exclusively for 4 to 6 months, with the addition of complementary foods beginning by at least 6 months, and continuing until 12 months is the ideal method for feeding infants. So breast milk is all the infant needs for about the first 6 months of life for optimal growth and development. With very rare exceptions, would the baby need something else besides the mother's breast milk. A lot of women will stop breastfeeding due to various reasons, and the type of factors that play a role in that are going to be the mother's age, the mother's education level, and where she lives. There are a lot of cultural and geographical sort of factors that will play a role in the woman's success of breastfeeding. Okay, so as far as how much more food you need to eat when breastfeeding. It is approximately 85 calories are needed for every 100 milliliters of milk that are produced. And this is going to require an increase of approximately 500 calories a day, but this fluctuates. So the amount of breast milk produced is always going to be in balance with the amount that the infant needs. So if you have a very hungry baby, then you'll produce more and you'll burn more calories and you need to eat more. But if your baby is still tiny and they don't eat as much, then you don't make as much. Protein recommendations are even higher than for pregnancy, but only slightly. So they say that you need an additional 25 grams a day over the non-pregnant rate. So that comes out to a total of 70 grams per day. Other nutrients that are needed in larger quantities than during pregnancy are going to be all of those vitamins there: A, E, C, B6, B12, and riboflavin. Why they didn't put B2, I'm not sure. And then the minerals copper, zinc, iodine, and selenium. And then an additional 1,000 milliliters a day of fluid. So water. You need to drink more water. As far as guidelines go for during breastfeeding, they're pretty similar to that of a pregnant woman. So they do recommend staying away from those high mercury sources of fish, but they still recommend, the 2 to 3 servings of fish. High protein foods include 6 to 8 ounces of meat or meat substitute daily. Substances consumed by the mother can affect the breast milk. And so, especially alcohol is going to be the one that most people know, but any drugs or all drugs, caffeine, all of those things can impair or be transmitted to the infant through breast milk. Alcohol can impair milk flow. So, depending on, how much milk the mother can produce. And then MyPlate, it does the same thing as it does for pregnant women. It does have a lot of nutrition guidance and tips as far as what to eat and how to eat during that stage of life. So dietary assessments of routine food should be made by a registered dietitian, and then that person makes those suggestions on how to alter the food. In your book, it has on page 248, which this is not something you're going to get tested on, but it goes over the advantages of breastfeeding there. They break it down for the mother and for the infant, and I think they're pretty interesting as to why women maybe would consider breastfeeding. So oral contraceptive agents, these are birth control pills. And so when a woman, obviously she's not pregnant, she could be lactating and taking oral contraceptives, but not usually the same ones as you would take when you're not breastfeeding. And so oral contraceptives will negatively affect the absorption of vitamin B6 and vitamin B12 and folate. Why they didn't say vitamin B9? Not totally sure. Progestins can cause weight gain, which can be related to an increased appetite and altered carbohydrate metabolism. So we all know, the way that our insulin affects things, and there's a chance that the extra progestins can make the individual more insulin resistant, but that's just one of the risks of birth control. And then changes in lipids, increasing risk for heart disease. So there are undesirable decrease in high density lipoprotein cholesterol levels and an elevation of low density lipoprotein and total cholesterol levels. So some women will have this effect where they begin taking birth control and it has an effect on their cholesterol levels, and so they might consider using an alternative form of birth control instead. The increased amounts of pyridoxine may be indicated because those estrogen increases the production of tryptophan. I think it's really cool that your book goes into this specifically. because there is an increase in tryptophan, which uses pyridoxine in its metabolism. So then low levels of vitamin B6 are also independently associated with the risk for thromboembolism, so supplementation may be indicated. Okay, so menopause is going to be the next thing we talk about, and menopause is the end of the fertile years of a woman's life. And it typically will begin around the late 40s for a woman. Most of the time it happens in their 50s. There are roles as far as like the woman's genetics, her overall like general health, and of course how old she is going to play a role in when this process begins. As like the first couple of years, as the, her body sort of begins to go into menopause, there's going to be a sort of cluster of symptoms that are known as perimenopause, or the loss of bone density, hot flashes, sweats. Your book goes into fatigue, insomnia, loss of bone density, and mood swings. Oh, and changes in menstruation. So all of these symptoms can be the sort of marker for the beginning of menopause. Menopause is decreased production of estrogen and progesterone by the ovaries, which will result in the termination of menses, or the monthly cycle, right? Reduced estrogen is going to affect bone turnover, resulting in decreased bone mass density. And how this happens is that the estrogen receptors on bone-resorbing osteoclasts will actually increase activity in response to the estrogen level, while estrogen receptors on the bone-forming osteoblasts will decrease their activity. And so there will be more bone resorption than there is bone like forming or bone building. This bone resorption is going to affect significantly the trabecular and the cortical bone loss. So this is something we need to pay attention to as women age. Their response, their overall bone mass when it comes to their alveolar bone in periodontal disease is going to be affected differently than when they're not in menopause or perimenopause. It will gradually decline. So during perimenopause and for maybe up to a few years into menopause, they're going to have a lot more bone loss, more rapid, but then it's going to kind of slow down and level out as the woman continues to age. And then alveolar bone is labile source of calcium, and losses may indicate early osteoporosis. So when we see, alveolar bone really resorbing without a significant periodontal, not periodontal disease kind of resorption, but like a darkening of the areas that aren't affected by periodontal disease, then it could indicate early osteoporosis. All right, so as far as the effect that menopause has on oral health is going to be in reducing salivary flow, which, we've talked about it the entire book, so that is pretty important for oral health, right? The other thing is that it could have gingival effects. It says atrophic gingivitis. In the book, it's actually senile atrophic gingivitis, which I think is rude way to say it. And then menopausal gingivostomatitis, which menopausal gingivostomatitis is kind of like a white sort of appearance to the tissue, almost like the tissue's just blanched. And it's, the tissue is going to be very firm, dry and shiny. It can go pale, which is what I think of, but then your book does say it can also get pretty red too, so it just depends. And then an exaggerated response to plaque biofilm. There can be increases in body fat and declines in body lean body mass. So for women, as the estrogen and progesterone change, they can lead to weight gain. And then your book talks about hormone replacement therapy. It's a controversial treatment, but it does reduce the risk for osteoporosis. So when women take estrogen, right, a supplement form of estrogen, then it does increase their risk of breast cancer, but it's going to reduce their risk of osteoporosis. So most of the time, as a woman is going through menopause and perimenopause, they'll do hormone replacement therapy, but then as those levels, kind of start to balance out after things have settled down, then they'll stop taking the HRT. Your book also talks about plant-based foods like legumes and soybeans, and these provide something called phytoestrogens and soluble fiber. So soluble fiber is really important because in the gut, soluble fiber will help to bind free-floating estrogen and carry it away so that it doesn't get reabsorbed, and that's a good thing in menopause. And then a lot of people talk about how soy products can increase your overall estrogens, but what it does is it kind of blocks some of the receptors that are bad that will cause breast cancer. So as far as soy products and soybeans go, they're actually really beneficial for reducing estrogen levels, but in like a good way, and it reduces a lot of the menopausal symptoms, and it can reduce risks of breast cancer as well. So that is it for chapter 13. The health application for this chapter is going to be fetal alcohol spectrum disorder. That starts on page 252 if you are interested in reading about fetal alcohol syndrome.